صباح الخير، انتوا سامعيني كده؟
سامعين حضرتك يا دكتور هشام؟
مين، احمد ولا مين؟
احمد محي.
ازيك يا احمد؟ طيب تمام. النواب طلعوا ولا لسه؟
اه موجودين، يبدأ يطلع.
طيب. دكتور احمد عادل عندك؟
موجود محاضرة دلوقتي ما سنتش.
احمد ازيك، عامل ايه؟
صباح الخير دكتور هشام، ازي حضرتك؟
بقول لك احنا ويل ستارت كده مثلا 9:15 بالظبط.
اوكي انا جاهز كده خلاص، انا كده وصلت كل حاجه، ناقص بس هتقول ابتدي على طول.
لا بتهيألي عشان بس النواب طالعين، مريم جاية كده يعني. خلاص انا قلت لها تبلغ النواب. ف9:15 بالظبط ويل ستارت، هقدمك ويل ستارت. اوكي
اوكي
ماشي. انت محاضرتك هنخلص على 10 مثلا، مش كده؟
ان شاء الله.
ماشي. في ايكو على فكرة، ده بيحصل نتيجة لو حد فاتح الموبايل بتاعه كمان على البتاع.
اعمل موبايلك ميوت، يعني الزوم نفسه اعمله ميوت. لا ده مش شغال لسه، هذا مش شغال.
يعني لو احمد، لو انت مشغل موبايلك على الزوم، اقفله. فاهم
انا
قصدي؟
انا مش
واشتغل
مشغل.
بس عن طريق اللابتوب عشان ما يعملش ايكوين كده. يعني
تمام.
او احنا بالظبط، يعني احنا دلوقتي كمان 5 دقايق من دلوقتي we'll be starting ان شاء الله. وابتدي يعمل شير سكرين بقى كده يا احمد.
حاضر.
يلا شكرا.
كده كويس دكتور هشام؟
كده كويس، بس اتكلم كده يا احمد.
حضرتك سامعني كده كويس؟
ممتاز كده، ممتاز، فيري جود. اوكي تمام، يبقى احنا قدامنا 4 دقايق ونبتدي ان شاء الله يعني.
لا لسه.
صباح الخير.
صباح الخير دي.
انت جاهز يا احمد؟
انا جاهز اه.
اوكي، وفي نواب كده حاضرين وكده؟
لا لسه ما طلعوش.
احمد محي عندك ولا؟
اه محي.
طب خلي احمد
طالعين
محي.
حالا.
طيب
طالعين
اوكي،
حالا.
تحب نديهم كمان 5 دقايق ولا حاجه يا احمد؟
خلاص ماشي مفيش مشكلة.
تمام.
Okay. Give them another 5 minutes كده، واستعجلهم يا محي. ها
حاضر.
صباح النور.
اوكي. احمد let's start كده بقى.
اوكي.
طيب صباح الخير. It's my privilege النهارده ان احنا to continue again ان شاء الله في ال Acute Cardiac Care sessions، واعتقد ان هي دي هتكون اخر سيشن للعام الدراسي دوت، و we'll be taking a break بعد كده لغايه اول 9. النهارده يسعدني ان يكون معانا بروفيسور احمد عادل، واحمد يعني من الناس المتميزين جدا علما وشطاره وكل حاجه، واحنا اخترنا له موضوع ظريف هو مش ظريف قوي يعني، ولكن في كلام كتير which is acute cardiac care in the elderly. فأهلا بيك يا أحمد. We are sure that you will be giving us a great presentation as usual. تفضل.
Thank you, Professor Dr. Hisham, for the nice introduction. Good morning, everyone. Today we're going to talk about acute cardiac care in the elderly, and this is an important topic because this is a special population that deserves to be focused on because they have their peculiarities, and they have their massive comorbidities, and they are fragile people who deserve special considerations and attention. Actually, the elderly population is getting bigger and bigger worldwide. In the US, for instance, we can see the difference between 1980 and the projection for 2025. We can see that in the 80s, the main population was the young people. And as we get older, the number of population decreases. But in 2025, it's expected that the elderly population will be almost similar to the young population. And this is not only in the US, this is also in the European Union. We can see that along the years, the elderly population is getting bigger and bigger. And the problem is that because we have many elderly population in our societies, and we don't have much representation of these populations in studies, because most of the studies by default choose people in the middle age group. They usually exclude young people and old people, unless, of course, the study is aiming to target the old population. Otherwise, they are not represented that much in trials. And so we cannot extrapolate most of the studies and most of the results that we have on the elderly, because they are a special group, as I told you before. And because they are getting larger in our society, it's not uncommon to find an elderly in the ER nowadays. And with all his chronic medical, social, and psychiatric problems. And also they have their own atypical symptoms and presentations. For instance, if we talk about acute coronary syndrome, for example, we'll find that the incidence of acute coronary syndrome is on the rise in general, but especially in the elderly. We can find this graph is about men above the age of 74. We can see it's progressively rising. The acute coronary syndrome in this population is getting higher and higher. And the same goes for women above the age of 74. While in men between 25 and 74, it's almost stationary, and the same applies for women in the same age group. So the incidence of acute coronary syndrome is increasing in the elderly population. They also have atypical symptoms, and as we know, atypical presentations and symptoms of acute coronary syndrome or myocardial infarction is mainly in the elderly and post-operative patients, in diabetic patients, in women, and also maybe in the very young population. But if we have an elderly person, he's liable to have an atypical symptom, especially if he is also a woman and diabetic. And if it's post-operative, if he has all the risk factors for having atypical presentations, then we can very easily misdiagnose this patient. And the cause, and it's important to know that elderly usually present with dyspnea in about 50% of cases of acute coronary syndrome, especially if they are above the age of 85. And they also have the angina equivalents like fatigue, increased heart failure, altered mental status, and syncope in 20% of cases. So it's not only about chest pain in this group. And the prognosis is poor. In general, the mortality is twice as high as the middle-aged persons. And the problem is that the pain perception is different in the elderly population. They have reduced pain because they have ischemic and damaged sensory nerves. They also have ischemic dysfunction of the cerebral cortex, and they have also dysfunction of the autonomic nervous system. That's why the pain perception in this group is different. Also, they don't usually sweat, they don't usually have nausea or vomiting, and they have different risk profile. And if you can see in this study that was done in 2009, we will find that if we compare patients with above the age of 75 and those below the age of 75, we can see that the chest pain was significantly more common in those younger than 75. Whereas the dyspnea and fatigue, it's much more common in the age of above 75. And the STEMI is more common in the younger population, while the non-STEMI is significantly more common in the elderly population. And also, it's not about the symptoms that they have. The cardiac risk profile is different in the elderly. We can see that women are more common in the to have acute coronary syndrome in the elderly. Smoking is less common in the elderly. History of ischemic heart disease, hypertension, and diabetes are much more common in the elderly than in less than 75 years.
طب أحمد معلش يعني لنا كده ايه الحاجات اللي بتبقى more common في الالدرلي عشان الدكاترة معانا الصغيرين يعرفوا. يعني دلوقتي انت لما يكون عندك حد على فكرة وقصة above or below 75 ديت متاخده ان الجايد لاينز قررت كده، اعتبروا الالدرلي ده مش يونيفرسال ديفينيشن ولا حاجه، بس اعتبروا يعني في اوائل من يجي 20 سنه نزلوا جايد لاينز على النون ستامي والستامي في الالدرلي وقسموهم اباب وبيلو 7. فايه الحاجات البيكيولير لو واحد فوق 75؟ يعني ستامي اكتر ولا نون ستامي؟ دايابيتك هايبرتنسيف اكتر ولا لا؟
الحاجات المور كومن في الاباف 75 هو ان الشيست بين مش موجود او اقل بكتير، mainly angina equivalent, dyspnea and fatigue and that kind of stuff. And the non-STEMI is more common in the above 75 عن ال below 75. والعكس بقى في الاقل من 75 STEMI is more common عن الالدرلي. والريسك بروفايل مختلف، ان الومن اكتر في السن ال 75 سنه، اقل من 75 سنه it's more common to find males that have acute coronary syndrome than females. لكن above 75 الwomen بيشكلوا نسبه كبيره، about half of patients are women. وكمان الهايبرليبيديميا والهايبرتنشن والدايابيتس are more common في الالدرلي عن الاقل من 75. بالعكس بقى سموكينج مثلا اكتر مور كومن في الاقل من 75 عن
بلاش بالعكس. انا قصدي عايز تقول لهم بس اللي above 7 عشان يعرفوا يحفظوه، بس يعرفوا ده ايه. فيعني ال above 75 احنا عندنا more females عادة، او at least according to the study اللي انت بتوريها يعني. لان انا اتوقع ان هيكون برضه في ميلز، بس هو كمان انه الافريج لايف اكسبكتنسي للفيميلز اطول، واحنا عارفين ان الاثيروسكليروزس ديزيز اوف ايج، وبالتالي هنتوقع ان more elderly في الالدرلي population الفيميلز will be more عددا.
تمام.
فاحنا بنتكلم على females، بنتكلم على those having more risk factors, diabetics, hypertensives, and dyslipidemic are more common, at least in this study, in the elderly group.
تمام.
ماشي يا احمد، اتفضل.
وكمان we have other diagnostic issues. احنا قلنا طبعا ال non-STEMI is more common than STEMI، لكن كمان التروبونين is of less value في ال elderly عن ال younger generations because it has a lower specificity. Usually the specificity of troponins in acute coronary syndrome is about in the order of 95%, 96%, but in the elderly it's more in the order of 80-83%. And so we can get false positive diagnoses of acute coronary syndrome based on positive troponin in the elderly, while in fact it's not there. And also the ECG interpretation can be challenging because usually the elderly have some sort of myocardial damage that's slow and persistent over the years, and we can get the Q waves and some non-specific ST segment changes over the years without having an actual myocardial disease. So it could be a challenge if we have a baseline abnormal ECG to diagnose a non-STEMI, especially that the troponin is not that helpful in comparison to the younger population. And also, we also know that troponin gets higher in many diseases like hypertension, acute hypertension, and COPD, and that kind of stuff. But also in this study, for example, we can find that even age is a risk factor for troponin elevation, whether the patient has acute coronary syndrome or not. That's why it's not, you cannot rely completely on troponin elevation, especially if it's a mild elevation or marginal elevation in the diagnosis of acute coronary syndrome. So this adds to the misdiagnosis and misinterpretation and the difficulties in management of patients in the elderly population. Also, of course, we can find, because elderly usually have much more history of myocardial disease or myocardial infarction over the years, and they usually can have coronary angiography in comparison to the younger population, and PCI and CABG, their history, the long history based on the years he had alive makes him more prone to have a history of ischemic heart disease than the younger population. But also, we can find that in terms of myocardial infarction complications, recurrent myocardial infarction is less common in the elderly than those less than 75. And this is because usually myocardial infarction, because it has a worse prognosis and twice the rate of mortality. So usually patients die because of myocardial infarction and do not have recurrent MIs over the years. Maybe this is the most important explanation for this finding. But we can, the incidence of heart failure and strokes and unstable angina post-MI are usually not different between those of the elderly and those in the younger population based on this study. Another important issue is the delay of admission, because elderly people are frail and usually are based in nursing homes, and their symptoms are very vague. So they do not usually go to the ER that easily. And you can find here in this study then that it's more common to have patients less than 75 coming earlier to the ER in less than 1 hour and 2 hours. And those coming later than 6 hours are usually in the elderly group than those less than 75 years old. In terms of management, we also have some differences. Usually, there's no significant difference between both groups in terms of antiplatelets therapy and beta blockers. But they found in this study that ACE inhibitor use was more common in the elderly, and low molecular weight heparin was more common in the younger population. But the important thing is the reperfusion therapy. We can find in the reperfusion therapy that it was not significantly different in terms of thrombolysis between both groups, and this was striking for me, because the trend or the usual concept is that doctors are afraid of giving thrombolytic therapy to the elderly because of the bleeding risk. But in this study, they found that it was not significantly different, and this is a good thing to find. But the incidence of PCIs were more common in those less than 75 years old, and also CABG was not different between both groups. So to sum up, in the acute coronary syndrome, we can find that elderly may not receive aggressive treatment like PCIs, because it's a more invasive procedure, and people are afraid of putting those frail patients to invasive maneuvers. Older patients may have a greater absolute benefit of treatment, so they should not be denied invasive procedures if they need to. Less thrombolytic therapy is the trend, but in this study we found that it was not different. Less invasive strategies are the trend, and it's not a right thing to do. The recommendations is to improve, is to do techniques to improve ACS recognition, because as I said earlier, it's a difficult situation because patients have different symptoms. The troponin is not reliable. The ECG may be abnormal at baseline, so it may be difficult to diagnose acute coronary syndrome in the beginning, and so patients are presented late to the ER. And it's also wise enough to include older patients in the acute coronary syndrome trials, because they are now constituting a big part of the community. As for the prognosis, as I said earlier, it is significantly worse, and the mortality is higher, 19% versus 5% for those less than 75 years. This is in terms of acute coronary syndrome. If we turn now to another thing like pulmonary embolism, for instance, we find that the risk of pulmonary embolism increases over the years, and it's like an age, a function of age. But usually there are two steps of increase. Those above the age of 40, they have significantly higher risk of pulmonary embolism than those below the age of 40. And after the age of 60, the risk of pulmonary embolism doubles. And this is because of the parallel increase in risk factors like COPD, immobility, cancers, fractures of bones. All these things make patients liable for pulmonary embolism. And these things all accumulate over the years and become more prevalent over the years. Usually, presentation of acute pulmonary embolism is also different. Patients usually develop painless dyspnea, whether at rest or with effort. And there may be some non-specific STT changes. Syncope is more common in the elderly. And we can see in this diagram that pleuritic chest pain, tachypnea, tachycardia, all these things are more common in the younger than elderly population. So it's a bit difficult to diagnose pulmonary embolism based on symptoms, or at least to suspect pulmonary embolism based on symptoms alone. You should have a high margin of suspicion. On examination, it's not uncommon. It's not common to find unilateral leg swelling and signs of DVT in the elderly, and the rails are less common than in general population. D-dimer is also a problem because it has an increased sensitivity but poor specificity, because it also depends on age because of the renal clearance of the D-dimer. So you can have false positive results of D-dimer. And CT pulmonary angiography can be a problem because of the problems with the kidneys in the elderly, so may not be able to do CT pulmonary angio if the patient has a CKD, an advanced CKD. As for aortic dissection, it's also a big problem because diagnosis is usually difficult in all ages, and not only in the elderly. And the delays in the diagnosis is very common, and it's often misinterpreted as other diseases, and the diagnosis is usually accidentally discovered in the elderly while searching for other problems. And the risk factors for aortic dissection in general is hypertension, atherosclerosis, prior cardiac surgery, aortic aneurysms, and all these things are more common in the elderly than the younger population. So they are more liable for having aortic dissection. Chest pain, the characteristic chest pain of aortic dissection is specific, but is very insensitive. Type A aortic dissection is more common in more than 70 years, and type B has similar frequency in terms of pain between those older than or less than 70 years. The ECG changes of myocardial infarction can mislead you into diagnosis of myocardial infarction without having, especially in the inferior myocardial infarction, you can diagnose inferior only myocardial infarction without aortic dissection, while the patient has aortic dissection as well. Syncope may be the only presentation in the elderly. And also you have other variable presentations based on the branch of the aorta that's affected. You can have, as I said earlier, myocardial infarction if it's type A and the aortic root dissection with involvement of the right coronary. You can have neurological problems like syncope or stroke if the dissection involves the great vessels of the neck. You can have renal failure if it extends to the renal arteries. You can have limb ischemia, GIT ischemic changes like mesenteric ischemia and that kind of stuff. On examination, the pulse deficit is less common to find in patients above the age of 70, and of course it's more common in type A than type B. The diagnosis also relies on chest X-ray, CT, TEE, and MRI, just like the usual in the younger population. And usually type A dissection is treated surgically as you do in the younger population, while type B is managed medically. You can find in this study the differences between the survival in patients who were managed properly you can find that above the age of 70, medical treatment has very poor survival, and also medical treatment in less than 70 was also associated with less survival, while patients who were treated with surgical treatment, whether they were above 70 years old or less than 70 years of age, they did better. So if you offer patients who need surgical treatment surgery, whatever their age or irrespective of their age, they would do better than those who do not do surgery. And this is another graph showing this. You can find over the years, this is the gray bars are those who were treated medically, and the white bars are those who were treated surgically. We can find that as you increase in age, the difference in between medical treatment and surgical treatment in terms of death is lower, but people even above the age of 80 are offered surgical treatment for the aortic dissection, because this is important for their survival. But the margin of benefit is less, of course, than those who are younger, because people in the elderly are more prone to die even of other causes, not just the aortic dissection. So even if you treat the patient for aortic dissection surgery, he may die later in a year or so based on other comorbid conditions, not just surgery. And we come to this principle later on. Another important issue in the ER is the cardiogenic shock. And we all know that cardiogenic shock offers a very poor prognosis for patients, regardless of their age. This graph shows us that if a patient comes with no cardiogenic shock, the survival is very high. But if he has cardiogenic shock, the survival is very low. And it got better over the years, actually, because of the medical treatment and advanced life support measures and assist devices and that kind of stuff. So in 2010, cardiogenic shock was associated with less survival than in 1995, for instance. And this is a registry showing that the same trend in the 1995. Patients who were older than 75 developed cardiogenic shock in 11%, while those in less than 75, 5% only got cardiogenic shock. And this trend stayed similar over the years. And in this registry, for instance, we can, which recruited patients with STEMI who developed cardiogenic shock, we found that the incidence of cardiogenic shock in the elderly was 9%. And in this registry, we found that patients with cardiogenic shock did much worse than those who did not develop cardiogenic shock. So as the mean age of patients is increasing and patients are more commonly now doing surgeries, we can get cardiogenic shock post-operative. And this graph shows us that the rate of procedures that have cardiogenic shock increased with age in those above the 75 years old, and those from 65 to 75 years old, while those in the younger population, it stayed the similar. Now we have many methods to assist patients or to support patients with cardiogenic shock, like intra-aortic balloon, pump, impella, ECMO, and that kind of stuff. And if we come to the intra-aortic balloon, we know from the intra-aortic balloon shock 2 trial that there was no significant mortality benefit based on the intra-aortic balloon use, even in the general population, not only in the elderly. But if we come to the subgroup analysis, we find that the major benefit of the intra-aortic balloon was in the those less than 50 years old, whereas patients who are 50 to 75 years or above 75 years did not benefit at all from the intra-aortic balloon. That means that we should not subject patients to intra-aortic balloon pump support if they are old, because it's of no benefit at all. And the same applies for the ECMO and other ventricular assist devices, because actually this is controversial a little bit, because most centers do not advise using ECMO for patients above the age of 70, because of the worse outcome they have. And actually, some centers put it as a relative contraindication to use ECMO in advanced age, and others, like the ECMO Organization Society, put it as an absolute contraindication. But let's look at some registries. There's a general rule that says that science tells us what we can do, trials tell us what we should do, and registries tell us what we are actually doing. So let's see what we are actually doing. In this registry, for instance, we can find that across the years there has been a sharp increase in the use of intra-aortic balloons and mechanical circulatory supports, starting from the year 2008. And astonishingly, we can find that the incidence of the use of these circulatory supports got higher in those above the age of 80 from the year 2008 up to 2011 compared to previous years. And this is not similar in other age groups. So they have been using these advanced procedures in the elderly from the year 2008. However, this was associated with mortality because, as you can see, above the age of 80 years, the use of circulatory supports had a 1.5 times rate of mortality compared to younger or no circulatory support. And this is another registry that shows similar results. We can find that elderly patients who develop cardiogenic shock was higher, and age was one of the mortality predictors. So this means that the recommendations are correct. We should not use ECMO, for instance, in elderly, and it's relative or absolute contraindication. But actually, if we look at the Intermax registry, we can find that compared to those less than 70 years of age, those who had LVAD implantation, for instance, they did fairly similar to those younger patients up to 30 or 40 months. And then the curves started to separate, and mortality increased in the group of patients who are above 70 years. And this is because of the principle I was talking to you earlier, the competing causes of death. This is an important principle. Patients who are elderly have a lot of causes to die for. They can die of cardiogenic shock, and they can die of advanced lung cancer or kidney or renal failure or that kind of stuff. So even if you prevent death because of myocardial infarction or because of cardiogenic shock, that does not mean that patient will not die. He will die, but from other reasons. So it's important to calculate the risk of death of the patient before doing any advanced procedure for him. And that's why, for instance, in the ICD indications, we find that one of the indications is that the patient has a good 1 year survival before implanting an ICD, because if you implant an ICD in this patient, you will prevent death from cardiac disease, but you will not prevent death from advanced malignancy, for instance. So if the patient is going to die within 1 year because of advanced malignancy, you should not put an ICD and prevent cardiac death, because he will die anyway. So this is an important principle, an important concept to consider in this age population. There are other general considerations that we should put in mind. First of all, as I said earlier, most of the trials do not enroll patients in the elderly group, so they are not underrepresented in the trials, and so we cannot extrapolate the results of the trials in this age group. Another problem is the comorbidities, because it will affect the decision that you make. Patients having chronic kidney disease, having bleeding risk, anemia, and other comorbidities will influence the decision that you take. There's usually a decline in organ functions over the years, and it's a function of age. You cannot stop that. And the principle of competing causes of death, as I told you earlier, is very important and should be taken into consideration before subjecting those patients to invasive strategies. The polypharmacy is important because you are treating patients for cardiac disease, but he has other problems with the knees and with the neurology and with chest, and he is taking a lot of pills. So the compliance to medications is not that good. Not to mention the drug interactions that can arise because of this polypharmacy. And also, it's important to define what are we trying to do for these patients. Are we trying to save them from dying, or are we trying to improve their quality of life? Because in many situations, patients are only should only be targeted for quality of life and not survival. For instance, primary prevention programs with statins and secondary prevention programs with statins or ACE inhibitors, for instance, are targeting patients to live longer. But in the elderly, they already lived longer. They already achieved the old age that we are aiming for. So you should not aim for more age. You should aim for better quality of life. And with this, I will conclude my presentation. Thank you very much.
شكرا جزيلا يا احمد على المحاضره الرائعه. بس انت بتهيألك فعلا كده يعني الالدرلي مش مهم السرفايفل؟ بتهيألي انه الناس لو واحد سنه 85 ولا 90 سنه هيبقى ستيل برضه عايز يعيش اطول and he will be interested in so. يمكن الكلام ده كان من سنين طويله لما كانوا بيتكلموا بس ان احنا مهتمين على الكواليتي اوف لايف ومش مهتمين قوي بقصة السرفايفل في الالدرلي. بس دلوقتي لا خالص. people are very interested to live longer if we can be helping. وبالتالي it is still an important issue ولكن we don't have data enough which can be helping us in this issue. فميرسي جدا يا أحمد. لو في حد عنده أسئلة يجو أهد. أحمد سامعني؟
صباح الخير جميعا.
صباح الخير. ازيك يا دكتور محمد، عامل ايه؟
صباح الخير.
برضه عايز اشكر احمد واهنيك يا دكتور هشام على اختيار الموضوع ده موضوع مهم الحقيقه
جدا.
وفعلا زي ما احمد قال الايج ده هو الحقيقه يعني ار اكسكلودد من كل اللاند مارك ترايلز، وبالتالي احنا ما عندناش داتا نقدر نطبقها، وهم مختلفين باسبكتس كتيره وحتى يعني الريسبونس تو تريتمنت. وطبعا كلكم عارفين ان هو ريسبونس تو تريتمنت والميديكيشنز بيختلف. احنا محتاجين اكتر مع تزايد العمر متوسط العمر في مصر ان احنا تفوكس اكتر. احنا الحقيقه عاملين ريجستري على الاكيوت كورونري سيندروم في الالدرلي اكشولي في الاوكتوجينيريانز، وبنشوف برضو احنا بنعمل معاهم ايه والاوتكم بتاعهم شكله ايه وبياخدوا ستنس عددها قد ايه، وبصفه عامه الاتيتيود بتاع الاطباء مع الاوكتوجينيريانز. مش مفروض نتعامل معاهم ان احنا هم ناس ضايق، لا احنا نتعامل معاهم اكنهم ناس عاديين، بدليل ان احنا بنعمل التيفي لكل الناس اللي عندهم سن كبير، وفي نفس الوقت احنا كمان بتكلف مبلغ كبير، حتى الدوله بتسبونسر الحكايه دي. فانا بهنيك يا احمد وبهني الدكتور هشام على اختيار الموضوع. هوت توبيك وما زال مفتوح المناقشه يعني. شكرا جزيلا.
شكرا يا دكتور محمد. انا بس عايز اسالك يا احمد سؤال كده. دلوقتي يعني لو جالك واحد elderly, how will you deal وعنده acute coronary syndrome, how will you deal with him؟ يعني على ارض الواقع. يعني احنا دلوقتي سمعنا محاضره جميله وشفنا انه في peculiarities للelderly وان هم definitely they are having a higher mortality, maybe also having a higher morbidity, والبيزلاين بتاعهم already بيبقى اوحش، والاوتكمز بتاعت البروسيجرز usually are less satisfactory than the young. كل ده expected and known. بس بقى على ارض الواقع how would you be managing such a patient؟
خليني اجاوب مكان احمد او اسمع اجابتي واسمع كلام احمد كمان.
تمام.
ممكن يا
انت
هشام؟
بتساعده قوي يا دكتور محمد، مش فاهم في ايه.
لا انا جاهز بالإجابة.
لا هي اتس ديفرنت ابروتش.
اوكي.
انا لما بيجي لي حد اوكتوجينيريان بالذات، حد كبير في السن، لان برضه ما بتكلمش على حد عنده 65 ولا 70 سنه، لا حد فوق ال 80. انا بجرب ان بكون كونزرفتيف اكتر شويه، الا لو عندي حاجه من الريد فلاجز. عندي مثلا التروبونينز عالي، عندي دايناميك تشينجز، عندي تشيست بين ات ريست، عندي حاجه من الفيري هاي ريسك او الهاي ريسك كرايتيريا بتاعه الاكيوت كوروناري سندروم او عيان نون ستيمي. كل ده انا امشي في اتجاه، يعني استيمي او نون استيمي او هاي ريسك، بمشي في الاتجاه العادي اللي بتعامل مع الناس كلها.
اوكي.
لكن بعد ما اعمل كورونري انجو بيبقى الديسيجن مختلف. اولا نادر لما ببعد السن ده يعمل جراحه، ما ببقاش اجريسيف ابدا، ما بحطش دعامات كتيره، يمكن بدور على الكالبريت ليجن اعمله واسيب بقيه الشرايين. يمكن لو لقيت ليفت مين مثلا اقل من 50% ما بعملوش حاجه. فهو تاني الديسيجن في الاكيوت في الهاي ريسك بيشنتس الديسيجن بيبقى عادي زيه زي الصغيرين، بس في الانفيزيف ديسيجن الدنيا بتتغير شويه. ما اعرفش احمد رايه، ويمكن اسمع رايه كمان يا هشام.
اوكي يا دكتور محمد، كلام منطقي طبعا اللي حضرتك بتقوله ده يا دكتور محمد.
تمام. انا بالنسبه لي مثلا بشوف ايه بقى الحاجات اللي مع الديزيز اللي هو عند العيان ده. يعني مثلا ايه الفانكشنال كاباسيتي بتاع البيشنت، بيعمل ايه في حياته؟ هل هو 85 years old وقاعد في البيت وما بيتحركش غير الحمام وخلاص، ولا واحد رئيس مجلس اداره شركه وكل يوم والتاني في سفر في حته وعنده اجتماعات وبيشتغل وبيعافر وكده؟ كل الحاجات دي مهمه. مثلا ادي حاجه اكزامبل، انا كان عندي بيشنت عندها 85 سنه وكانت فيري فرايبل، عندها وزنها مثلا بتاع 50 كيلو 45 كيلو حاجه كده، وكل حاجتها هي قاعده في البيت ما بتتحركش بره الاوضه بتاعتها، وجالها انفيريور ستيمي والكرياتين بتاعها كان عالي، مش فاكر الرقم كام، بس الجي اف ار كان 35 30 حاجه كده، فكانت فيري لايبل فور رينال فيلير. فساعتها انا اتكلمت مع اهلها وات واز انفيريور ستيمي ولوكالايزد والفنتكل بتاعها نورمال في الايكو ما عدا فيري سمول سيجمنت اوف ريجنال موشن ابنورماليتيز. فكلمت معاهم ان في ريسك اوف دايليسيس لو احنا عملنا انفيزيف بروسيجر، حتى لو احنا استخدمنا كميه صبغه قليله لكن في ذيرز ذا ريسك. فساعتها اتفقنا ان هم والبيشنت بقت اوف بين خلاص، فخلاص ساعتها قلنا لا هنكونزيرف ايفن اف اتس ان انفيريور ستامي، لكن اتس سمول انفيريور ستامي، وعديناها بميديكال تريتمنت ومشيت كويس وخلاص يعني. فبس بقى لو انا عملت لها انجي وعملت لها بي سي اي للرايت كرونري اللي هو واضح ان هو ما كانش حاجه كبيره، ان هو الستامي ما كانتش جامده قوي، ودخلنا في رينال فيلير، ده هيزود البروجنوز اكتر، هيوحش
بس برضه زي ما الدكتور محمد قال يا احمد، يعني انت ممكن لو كانت العيانه هاي ريسك اند يو ليفت هير، ممكن تكون حظك حلو and she doesn't die خلال اسبوع ولا 2، بس ممكن تلاقي بعدها 2-3 she died. وبالتالي we have to go scientific زي ما كلكم بتقولوا. انا بقى يعني اللي انا عايز اقوله انه نمبر 1 انه في حاجه اسمها فريليتي اندكس، والفريليتي اندكس دوت بيديني impression where the patient is. يعني انا اذا كنت عايز اكزامبلز مثلا يا احمد هقول لك اكزامبل امبارح، عيانه مبلغيني بيها في احد المستشفيات البرايفت، العيانه داخله عندها كسر في رجليها، وبعدين بيعملوا لها اي سي جي لقوا دايناميك تشينجز وفي تروبونين عالي. طيب سنها كام؟ مش فاكر، كانت حاجه و80 سنه، ماشي عادي صوت. ولكن لما تسال بقى وتروح تبص عليها تلاقيها كومبليتلي ديمنتك، ما بتردش، مش عارفه عندها تشيست بين ولا لا، متوهه، فيري ثين وفيري فريل، وقاعده مكومه في السرير. what are you going to take her to the cath lab? no. وبالتالي اللي انا احب اضيفه على البرزنتيشن الجميله اللي انت عملتها ان احنا لازم نحط في بالنا the so called frailty index. في النهايه it's an individualized approach، مفيش عيان زي التاني. وبالتالي اما باجي ابص على عيان elderly انا حاطط في بالي الجايد لاينز بتاعه اليونج والاولد لانها محطوطه للكل، ولكن لازم يكون في عندي شويه ذكاء في التعامل. ازاي ان انا زي ما الدكتور محمد قال وزي ما انت برضو قلت يا احمد، انه لازم ما فيش عيان زي التاني، ولازم ان احنا نفكر قبل ما ادخل بالعيان what are the possible مكاسب اللي هحققها، وايه برضو اللي ممكن اخسره لو دخلت.
تمام.
ممكن اقول حاجه يا دكتور هشام بعد اذنك؟ وانا
مين
حمدي
معايا
نجاح.
بس؟ مين معايا؟
حمدي نجاح يا بيه.
يا حمدي ازيك؟ اتفضل.
الحمد لله بيه، ربنا يخليك. احنا طبعا
اهلا
يعني
بيك يا حمدي. دكتور حمدي مسجل
ازيك يا
معانا.
بيه؟
اهلا
حمدي
بيك.
ده راجل جميل جدا، انا عارفه
لا
شغال
حمدي
معايا في
مسؤول الزماله الحقيقه في المعهد
مم.
القلب، وهو مسجل دكتوراه على الموضوع اللي احنا بنتكلم عليه النهارده، Acute Coronary Syndrome in Octogenarians.
تمام جميل. اتفضل يا حمدي.
هي محاضرة جميلة جدا يا دكتور أحمد، وشكرا جزيلا دكتور محمد ودكتور هشام. الموضوع ده فعلا يعني مش انترستنج، موضوع اكستريملي انترستنج، لأن الديسيجنز فيه بتختلف كتير قوي. بس أنا يعني كان سؤالي، كنت عايز أعرف رأي حضراتكم في هي بوينت صغيرة خالص. يعني البيشنت دولت معظمهم بيبقى البليدنج ريسك بتاعهم عالي، فهل بتميلوا اكتر ان احنا في الهيبريد مثلا نخلينا على اللور سايد؟ يعني احنا لو هندي من 70 ل 100 انترناشونال يونت نخلينا على ال 70، ولا ديت مش بنستخدمها قوي وبنحط البودي ويت دايما، ولا بندي رفلي 10000 يونت على طول ليهم؟
هترد يا احمد ولا رد؟
تمام. انا بس مش سامع قوي. هو حمدي
بيقول لك انت
ازيك يا حمدي، اخبارك ايه؟
الحمد لله. ازيك يا دكتور احمد؟ ازي حضرتك؟
الله يخليك يا باشا، الله
يخليك.
يكرمك. انا فهمت ان هو عايز الهيبرين في القسطره، مش كده؟ 100 انترناشونال يونت بير كي جي، صح كده؟ ولا 70؟
بالظبط. في البيشنت دولت يعني في الاوكتوجينيريان، هل نخلينا على اللور سايد يعني على ال 70 انترناشونال يونت بير كي جي، ولا نخلينا على
لا انا اعتقد ان انا عن نفسي هدي ال 100 كلهم، بس بعد كده بقى يعني هبقى بيز باي الاي سي تي، هبقى جايدد باي اي سي تي بعد كده. لو هدي اي بولس اكسترا او حاجه، لو الموضوع هيطول مثلا، يبقى لازم ابقى اي سي تي جايدد بقى، ما بقاش بدي كده بلايندلي يعني.
احمد بس لو بتتكلم على واحده عندها 85 سنه وفريل والبادي ويت قليل يعني لا برضه انت you have to give according to her body weight الحقيقه يعني.
ما هو according body weight بالظبط، ما هو 100 انترناشونال بير كي جي، ففي الاخر جايدد باي بادي ويت.
لا
احنا
وممكن
لازم
تدي على الاقل
هنمشي
من كده كمان.
بالبودي ويت، لازم هنمشي بالبودي ويت. وبس هو دايما لما بيبقى مديك رينج بيبقى ليها قصد برضه. يعني انا مثلا دخلت ولقيت انه عنده very high thrombus burden، خلاص طب ما انا probably والعيانه is not a high risk of bleeding apart from the issue of her age، هدي النورمال دوز، فاهم قصدي؟ مش هدي الليس دوز. ما فيش big thrombus burden، هبقى ممكن more on the safe side يعني. بس هي it's a matter of judgment، it's a case by case يعني.
هو الايدج ده بيه فعلا يعني كيس باي كيس، حتى الديسيجن فيه كيس باي كيس يعني بصراحه.
انا عايز بس اقول لكم حاجه، برضو على موضوع الايدج ده. حاجه these patients are very fragile and they are very intolerant اثناء القسطره، واحيانا ما بتبقوش واخدين بالكم ان العيان معاه عنده very commonly aortic stenosis. aortic stenosis في وجود coronary artery disease بيخلي الامور سيئه جدا. sometimes مجرد انك تانجيج الكرونري كده وتحقن حقنتين تلاقي العيان ابتدى يدخل منك في هايبوتنشن كده. عشان كده لازم immediately لازم تشتغل بسرعه، وما تحاولش انك تطول قوي في البروسيجر، ما تسيبش بالساعتين جوه، مفيش حاجه اسمها كده. انا قصدي be very cautious while dealing with the very elderly. مش بتكلم بس على اللي فوق ال80، بتبتدوا تشوفوا ناس فوق ال90 already. عملنا كذا عيان فوق ال90 and this will be very soon a near norm يعني، انك تشوف عيانين بالايدج ده. لو ما فيش اي اسئله تانية دكتور محمد تحب تسال اي حاجه حضرتك او تقول لنا اي كومنت؟
انا بشكرك واتمنى ان احنا نكمل على الموضوع ده هو ونعمل ورك شوب فيه كمان، لان احنا تاني فيري هوت توبيك، عندنا كتير جدا من التساؤلات، ما عندناش جايد لاينز واضحه فيه، ما عندناش لاند مارك ترايلز تقول لنا نعمل ايه، اور ايجيبشن بوبوليشن مختلف. اتمنى ان احنا نكمل في الاتجاه ده يا هشام، وتبقى محاضره احمد النهارده.
انا مستغرب، انا فاهم ان الموضوع ده انا كنت ناوي اديه فعلا، اللي هو بتاع الاوكتوجينيريا فكويس ان حضرتك اديته اوريدي. بس انا شايف زي ما حضرتك بتقول انه فعلا اتس ا فيري امبورتنت توبيك، والمفروض فعلا نفكر نعمل ورك شوب فيه ونعمل فيه يعني an important issue، لانه فعلا it has its own picture. شور دي
يا
حاجه
ريت
فعلا
دكتور
مهمه
حمدي نجاح
جدا.
يشترك معانا ويقول لنا داتا
طبعا
من اللي هو عملها، ويا ريت يا شيخ، يا ريت يا ريت.
شرف ليا.
الله يخليك. ثانك يو فيري ماتش. اشكرك تاني يا احمد على التحضير الجميل والبرزنتيشن الجميله، وبشكر الاتنديز اللي هو came physical as well as those who joined us through Zoom. وطبعا بشكرك يا دكتور محمد كمان على اهتمامك ومتابعتك لكل الايفنتات في الاسم، وبشكر حضراتكم جميعا. شكرا جزيلا.
انا عايز اشكر كمان ميرنا على مجهودها الحقيقه. ميرنا طبعا يعني هي الحصان الاسود الحقيقه في كل الاكيوت كاردياك كير، وهي الكوردينيتور. وميرنا معلش عايز اطلب منك تصوري لي الاتندي وتبعتهم لي. انا شايف النهارده العدد اقل من المفروض، الناس لسه ما فاقتش قوي من الامتحانات، فتصوري لي لو سمحتي الاتندي عشان عايز برضو نبدا ان احنا نشوف مين اللي بيحضر ومين اللي بيحضرش. متشكر قوي.
شكرا جزيلا.
شكرا دكتور هشام. شكرا دكتور محمد.
شكرا قوي.